What's up, Ninja Nerds? In this video today, we're going to be talking about pulmonary hypertension. So pulmonary hypertension is just basically when there's high blood pressure, particularly within the pulmonary circulation. Like we call it high blood pressure, we call it like systemic hypertension. This would be pulmonary hypertension, so high blood pressure within the pulmonary circulation. Now, what we need to discuss throughout the process of this video is primarily focusing on the different types of pulmonary artery hypertension and then the associated causes within those types. We'll discuss the pathophysiology a little bit, and then what we'll do is we'll go into the classic clinical features, which is really only two that I really want you to know. And then we'll talk about kind of the big thing, which is how to diagnose pulmonary artery hypertension. There's lots of tests, so we'll have to go through those step by step. And then finally, we'll talk about how do we treat pulmonary hypertension, but really focusing on type 1. So let's actually get into the different types first of pulmonary artery hypertension. So we know that the basic definition here is that the pressure within the pulmonary arterial circulation is high. We should actually develop a number, right? So really what the number is if we were to really look here, the pulmonary arterial blood pressure here is somewhere around, so the mean pulmonary artery pressure is greater than or equal to 25 millimeters of mercury, is how we really kind of look at this. So that number within the pulmonary arterial circulation has to be greater than or equal to the mean 25 millimeters of mercury. Now, we have type 1. Now, type 1 is a really interesting one, and that's the one that we're going to focus on a lot throughout the process of this lecture. Now, type 1 pulmonary artery hypertension is pretty much the basic concept behind this, is that the pulmonary vessels are super vasoconstricted. And the pulmonary vascular resistance to these pulmonary blood vessels, they're super clamped down. There's a very high pulmonary vascular resistance. Now, we know that as you increase resistance to blood flow, that does what to the actual pressure? It increases the pressure. So as I increase the pulmonary vascular resistance, I increase the pulmonary artery pressure. And what do I increase the pulmonary artery pressure to? To at least the mean amount greater than or equal to 25 millimeters of mercury. So now the pressure within this pulmonary circulation is super, super high. It's really high. And what that does is that creates a strain on the right heart. And because if the pulmonary artery pressure is super high, that'll put a lot of strain on the right heart, which will cause the right heart to undergo right ventricular hypertrophy, and then eventually go into right heart failure. So you see the process here, right? Pulmonary arteries super vasoconstricted. As you cause intense vasoconstriction, the pressure within the pulmonary circulation rises. As the pressure in the pulmonary circulation rises, it puts strain and stress on the right heart. The right heart will have to hypertrophy to try to get thicker and develop higher strength and contractions to push blood out to it. And then eventually that will cause it to fail. My question to you is for type 1, what causes this pulmonary vasoconstriction that causes intense vascular resistance? Great question. The basic pathophysiology is if we were actually cut this vessel, and then what I want us to do is actually look at this and zoom in on it at this view here. I'm taking a cut of the vessel. We're going to take a cut of this vessel here. And we're going to look at it. I want you to understand here something that happens. Naturally, to keep our vessels dilated or constricted, there's a kind of a homeostasis between vasodilation and vasoconstriction. On this top one here, what we're going to do is we're going to have these endothelial cells, which are in blue, and then this is the smooth muscle around it in red. These kind of endothelial cells can make a particular chemical here called endothelin 1. And what endothelin 1 does is it is an intense, and I mean potent, vasoconstrictor. And what it'll do is it'll cause this smooth muscle to intensely vasoconstrict. It'll cause it to contract, which will cause the blood vessel to decrease in diameter and increase the peripheral vascular resistance. Thus this process here. So it'll increase the vasoconstriction. The other thing is that we have these endothelial cells, and they also make other molecules called nitric oxide and PGI2, which is called prostacyclin. And what that does is that acts on the smooth muscle and inhibits the smooth muscle from contracting. And if it inhibits the smooth muscle from contracting, it should generally cause the muscle to relax, increase the actual vessel diameter, and decrease the peripheral vascular resistance, right? In this disease, type 1 pulmonary artery hypertension, There's a couple different things that can cause this process, but the basic etiology, the basic pathophysiology, if you will, is there is an increase in the vasoconstrictive process and a decrease in the vasodilation process. So there's less nitric oxide, less prostacyclin, which leads to less inhibition and therefore less vasodilation. So there is a decrease in the vasodilation. And when you take the combination of an increased vasoconstriction and a decreased vasodilation, what do you get? The increased peripheral vascular resistance, therefore increasing the pulmonary artery pressure, putting strain on the right heart, causing it to eventually fail. You guys get the whole point here. Now, the question that you might be asking is, what kind of things actually cause this? That is a great question, and here's what I want you to understand. One of the big things that I really want you to understand as a potential cause here is that it may be idiopathic, but we have to understand that this is a diagnosis of exclusion. The second thing I want you to remember here is it could be hereditary. So this could be hereditary where there is a particular gene, and some reason they like to ask this sometimes in the exams, which the gene is the BMPR2 gene. And this gene may also, again, accelerate this type of process, where you have genes that are activated that cause an increase in the vasoconstriction, so an increase in the endothelin-1 production, and a decrease in the nitric oxide and prostacyclin production. Here's the other thing I want you to think about. This could be due to connective tissue diseases. Connective tissue diseases that cause intense endomyofibrosis and medial hypertrophy. So I want you to remember, another thing here is it could be connective tissue diseases. And the connective tissue diseases that are actually worthy of remembering here is going to be two. One is called SLE, and the other one is called scleroderma. Don't forget these, okay? The next thing is this one's really interesting. It could be due to HIV. We don't really know how this actually happens, but HIV may potentially cause this problem as well. So I also want you to remember that HIV is another potential etiology here. The next one that I want you also to understand here is going to be something called portopulmonary hypertension. So portopulmonary hypertension. This is a really interesting process. So basic concept here, basic concept. Your liver is supposed to clear vasoactive molecules, right? So molecules that cause vasoconstriction. Imagine for some reason you have a damaged liver, right? So your liver's damaged. The chemicals that are supposed to go through this, it's gonna clear, because then it goes into the inferior vena cava. From the inferior vena cava it goes into the right atrium, right ventricle, pulmonary arteries. What if these chemicals that the liver's supposed to clear and remove, it doesn't remove? And these chemicals cause an increase in the vasoconstriction and a decrease in the vasodilation. That will cause increase in the pulmonary vascular resistance. So think about portopulmonary hypertension in patients who have underlying cirrhosis. The other thing that I want you to think about here is any kind of situation where there is an increase in pulmonary blood flow and they have to adapt. This is a big one in little babies. As they get older, they may develop this, and this is called left to right shunts. So as you have left to right shunting, so you have a big VSD, an ASD, a patent foramen ovale, what happens is you push a lot of blood from the left heart to the right heart, and that overflows the pulmonary circulation, and it has to adapt to that high flow, so it undergoes intense vasoconstriction, thickening of the actual vessels, medial hypertrophy, all that stuff. So here's the things that I want you to remember. But what is the most common out of all of these? The most common is going to be idiopathic. But in other words, we have to rule out all of these other ones as well as all the other types of pulmonary artery hypertension. So that's why this can be somewhat difficult disease. So understand type 1, the basic pathophysiology. The basic pathophysiology is there's an increase in vasoconstriction processes, a decrease in vasodilation processes, causing an increase in peripheral vascular resistance, increasing the pulmonary artery pressure, putting strain on the right heart. Idiopathic is the most common cause, then heritable, and then think about connective tissue diseases, think about HIV, think about portopulmonary hypertension, think about also left to right shunting as well. Don't forget these things. Okay, type 2 pulmonary artery hypertension. In this part, it's actually due to the left heart. So it's left heart disease. I don't want to even make it too complicated here. It's just a patient has left heart failure. If they have left heart failure, or valvular heart diseases, or maybe they have valvular heart disease, what this does is this causes a increase in pulmonary venous backflow. If blood is backflowing from the left heart into the pulmonary veins, it backflows into the pulmonary veins and then into like the pulmonary area here. Now this is going to cause so much congestion in this pulmonary circulation here. Same thing here, it would back up into the pulmonary venous circulation and cause intense congestion in this area. That's going to increase the pulmonary artery pressures. So that will cause an increase in the pulmonary artery pressures. As the pulmonary artery pressure increases, what does that do to the right heart? Strains it. What does that cause? Right ventricular hypertrophy. What does that cause? Right heart failure. Okay, so type 2 is left heart diseases, such as left heart failure, valvular heart diseases. Type 1, it's increase in vasoconstrictors, decrease in vasodilators, idiopathic, most common. Type 3 pulmonary artery hypertension is a lung problem. So in patients who have underlying lung disease, right? So for example, things like COPD or things of that nature like interstitial lung disease or obstructive sleep apnea, obesity, hypoventilation syndrome. These are the most classic cases, but it's a pulmonary disease. What happens is there's disease of multiple lung parenchyma. So here we're gonna just kind of like scratch out here. Here's some diseased lung parenchyma. 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 Okay, in areas where there's diseased lung parenchyma, there's inadequate ventilation, right? So if there is low ventilation here, low V here, low ventilation here, low ventilation here, low ventilation here. Do we want blood flow to go to the poorly ventilated areas? No. And if I don't want blood flow to go here or here so I can send it to other areas which are well ventilated, what's gonna happen? I have to constrict the pulmonary vessels to direct it away from these poorly ventilated areas and areas of good ventilation. So I constrict the pulmonary vessels. If I constrict on the pulmonary vessels, I'm going to constrict here. What it's going to do is it's actually going to cause the pressure within this, it's going to cause the resistance to go up. So because of this, the actual decreased ventilation or the hypoxia that may actually occur here, so the decreased ventilation will lead to hypoxic, what we call vasoconstriction. And that hypoxic vasoconstriction will do what? It'll actually cause the pulmonary vessels to actually vasoconstrict. That'll increase the pulmonary vascular resistance. If you increase the resistance in these vessels, what do you do to the pulmonary artery pressure? You increase it. Then you put strain on the right heart. That causes right ventricular hypertrophy. Eventually it goes into right heart failure. So, type 1, idiopathic, increased vasoconstrictors, decreased vasodilators. Type 2, left heart disease. Type 3, pulmonary diseases. Type 4. Okay, in type 4, this one's actually really an interesting one as well. Let's imagine you have chronic pulmonary emboli right here. So here's some tiny little distal pulmonary emboli. If there's distal pulmonary emboli, so this is actually what kind of situation here? The patient has chronic pulmonary emboli. That's going to cause, again, blood is supposed to go from the right ventricle over into the pulmonary circulation. But as it does, it's going to hit some resistance to blood flow. As there is an increase in this peripheral vascular resistance due to clots. So you see how we're getting the difference here? That vasoconstriction in type 3 was because of hypoxia or poorly ventilated areas. This kind of like area where it's not really a vasoconstriction, it's an increase in peripheral vascular resistance because of clots getting in the way. Whereas type 1 is an increase in peripheral vascular resistance because the actual vessels are contracting because of those pathways. So understand the difference. Type 1, increased vasoconstriction, decreased vasodilation due to these particular diseases. Type 2, pulmonary venous backflow, congestion. Type 3, hypoxic vasoconstriction due to lung disease. And type 4 is increase in peripheral vascular resistance due to clot burden, distal. So now I'm going to have an increase in peripheral vascular resistance due to these clots. That's going to increase the pulmonary artery pressure. That's going to put strain on the right heart, causing right ventricular hypertrophy and over time, right heart failure. Okay, type 1, increased vasoconstriction, decreased vasodilation due to An increase in endothelin 1, decrease in prostacyclins due to idiopathic mainly. Type 2, left heart disease, pulmonary venous congestion, and then pulmonary artery pressure increases. Type 3, lung disease causing hypoxic vasoconstriction, increasing resistance. Type 4, clots blocking the flow of blood from the right heart, increasing resistance, increasing right heart strain. Type 5. In type 5, this is usually multifactorial, but I only want you to remember 2 particular causes. If someone has like a big granuloma, right, and sarcoidosis. So they have sarcoidosis, and this is compressing on some of the pulmonary vessels. So you have a patient who has, what's this disease called here, this big granuloma? This is sarcoidosis. And what it's doing is it's compressing on the pulmonary vessels. If you compress on the pulmonary vessel here, what are you going to do to the resistance in this vicinity? Increase it, because you're compressing it from the outside. So I'm increasing the peripheral vascular resistance. Or if someone has a tumor, maybe they have a tracheal tumor, a bronchial tumor, they have lymphoma, something of that nature, a mediastinal tumor that's compressing the pulmonary artery. If I have a mediastinal tumor, these will compress on the pulmonary vessels and do what to the pulmonary vascular resistance? Increase it. If I increase the pulmonary vascular resistance because I'm compressing the vessels from these granulomas or tumors, I do what to the pulmonary artery pressure? I increase the pulmonary artery pressure, I put stress on the right heart, causing it to have right ventricular hypertrophy, and eventually go into right heart failure. That's how we explain pulmonary artery hypertension. Now, we have the patient with pulmonary artery hypertension. How does this increased pulmonary artery pressure, the right heart strain, potentially right heart failure, how does that actually present? Let's talk about that. All right, so how will these patients present? Well, here's the big thing. You already kind of saw I talked about this a lot, is that patients may progress to right heart failure from chronic pulmonary hypertension because they're put on a lot of stress, right? In the same way patients may develop heart failure from systemic hypertension, so left heart failure due to severe chronic hypertension. Same thing can happen with right heart. So as you have chronic pulmonary hypertension, you can lead to right heart failure. So obviously one of the classic things that we would look for is evidence potentially of right heart failure, right? So whenever patients have right heart failure, it's obviously something that we've kind of talked about before, but how will these patients present? It's not super complicated. If the right heart fails, blood backs up, right? So blood will back up where? It'll back up into the superior vena cava, and then up into the jugular veins, and then distend these bad boys. So the patients could potentially develop jugular venous distension. So look for jugular venous distension. It could also back up into the right atrium and into the inferior vena cava, swell up the liver, leak into the abdomen, and cause ascites and hepatomegaly. So we can look for ascites. We can look for hepatomegaly. It could also kind of cause fluid to leak backwards into the interstitial spaces of the lower extremities, cause pedal edema. So they may also have some pedal edema or peripheral lower extremity edema. So look potentially for evidence of that. So these could be some of the potential features that you may see from the right heart failure from that high stress. But here's the other thing. When you put that heart under so much strain, the other thing that you can see is evidence of right ventricular hypertrophy, right? So if the heart, imagine you take the stethoscope, put it on the chest where like the pulmonary artery is, and you're trying to listen to the different heart sounds. If the pulmonary blood pressure is so high that whenever you shut, for example, if patients have really severe systemic hypertension, what would that do to the actual aortic valve? It would snap that sucker closed really hard and would cause a loud S2, particularly the aortic component. And the same way, when the patient's pulmonary pressure is really high and they go into diastole, it smashes that pulmonary valve closed very quickly. So the other thing that you may potentially see with these patients as evidence of really their right ventricular hypertrophy is you may hear potentially, one of those things is a loud S2, but particularly the P2 component. All right, so the P2 component of the S2, because you know it consists of the aortic valve and the pulmonary valve closing. The other thing is that if you go to place your hand on their chest, on their kind of like right parasternal portion there, or just a little bit to the side here, you may have a heave, right? So they may have a right ventricular heave. So look for any evidence of a right ventricular heave as well due to that intense right ventricular hypertrophy. So these would be some of the things that you may see. Now, this is not classic, right? You know what the most classic symptom is for patients who have pulmonary hypertension? And I really don't want you guys to forget this. The most common symptom is exertional dyspnea. And you may be like, well, that kind of sounds like heart failure or coronary artery disease and things of that nature. That's one of the things that most oftentimes people have maybe missed the diagnosis of, pulmonary hypertension because it looks like CHF or, some type of coronary artery disease. It's really important to remember this. So exertional dyspnea happens to be the most common feature. Now, why? If the pulmonary artery pressure is crazy high, your right ventricle is going to have difficulty getting blood into that high pressure system and delivering blood to the left heart. So the whole concept here is that with this high pressure, there's going to be less blood moving through the pulmonary arterial circulation and entering into the left heart. Less blood is in the left heart now. That means less left ventricular cardiac output. That means I deliver less oxygen to the tissues now. So less oxygen delivery to the tissues. Now, imagine here, you have the patient exert themselves. So now their tissues are going to consume more oxygen. So if I have less oxygen delivery, and on top of that, let's say for this patient, I increase their O2 demand. How do I do that? I exert them. I have them run. I have them walk. I have them climb up stairs. When this happens, you create a mismatch. And that mismatch there, whenever they exert themselves, so this would be during exertion. And this decreased oxygen delivery to the tissues is just basically because of less blood getting to the left heart. Because of that, this combination will lead to dyspnea. And this dyspnea is particularly dyspnea on exertion. This is the most common feature for these patients. They may have some syncope on exertion as well due to less oxygen delivery to the brain tissues. They may have chest pain due to less oxygen delivery to the myocardium, but this is going to be the most common type of symptom, which is dyspnea on exertion. Please don't forget that, all right? So look for evidence of right heart failure and look for any exertional symptoms, dyspnea on exertion, exertional syncope, exertional chest pain. But this one is by far going to be the most important. But if you wanted to, don't forget syncope, okay, on exertion and angina on exertion. Let's also move on to the next part here, which is going to be talking about how do we actually diagnostically approach pulmonary hypertension. We have a patient who comes in, they present with evidence maybe of right heart failure, some dyspnea on exertion or some dyspnea, some exertional syncope, some exertional chest pain. You work them up for all these different types of disorders and you're trying to figure out, do they have a pulmonary artery hypertension? And if they do, is it type 1? Is it type 2? Is it type 3? Is it type 4? Is it type 5? But really the one that I absolutely want to figure out is it type 1 pulmonary artery hypertension? So let's talk about how we get to that. All right, so now let's move on to the next part, which is how do we diagnostically approach patients who have some type of pulmonary artery hypertension? So first off, it's clinical suspicion, right? So for example, if you have a patient who has exertional dyspnea, exertional syncope, exertional angina, that's definitely high yield stuff to think about. But then on top of that, I also think it's important to be able to understand, do they have any evidence of right heart failure due to that high pulmonary artery pressures, right heart strain, right ventricular hypertrophy that progress them into right heart failure, okay? Then think about the classification, type 1, type 2, type 3, type 4, type 5, right? So type 1, is it some type of like problem where they have increased vasoconstrictors, decreased vasodilators, right? We talked about that. Is it a left heart disease? Is it a lung disease? Is it chronic thromboemboli with pulmonary emboli, basically? Or is it a type 5, less likely, but some type of compression due to mediastinal tumors or sarcoid? So how do we do this? First thing is if you have a degree of clinical suspicion, this is usually not going to be a patient who comes into the hospital or to the clinic with rip-roaring hypoxemia, tachypnea, things like that. It's exertional dyspnea, exertional syncope, exertional angina. Start off with a plethora of tests to really try to elucidate this. One of them may be an echocardiogram, a VQ scan, a high-resolution CT, a polysomnogram, PFTs, EKG, and labs. You're like, what the heck? So first one, I do the echo. Why do I do the echo? Okay, I do the echo because the whole point of the echo is to first off rule out that this is a type 2 pulmonary artery hypertension. Because what is type 2? Left heart disease. Is there any wall motion abnormality? Is there any reduced ejection fraction? Is there any valvular heart disease? Right there, I can automatically determine that. The other thing is, the echo is very helpful for looking at that right heart. If you have high pulmonary artery pressures, what are you going to expect with the right ventricle? You may see some right ventricular hypertrophy, but over time you may see evidence of right heart failure, which is right ventricular dilation or right atrial enlargement. So these can be some big booming right side of the heart. That stuff could be big. All right, so look at a big right ventricle, big right atrium. The other thing here is usually in these patients, this would be the first thing that I would like to do. So let's actually take a quick look at an echocardiogram of what that would look like in a patient who may has pulmonary artery hypertension. All right, so if we take a look at this echo here, what we're looking at is we're looking at the right side of the heart. So you can see here left ventricle, left atrium, right ventricle. So this is a nice kind of like an apical 4-chamber view. And what we really see here is look how huge the right side of the heart is. So there's definitely like some right ventricular dilation, even a little bit of hypertrophy here. And then there's pretty like a significant right atrial enlargement. And if you were to look at the inferior vena cava, which would probably flow off of this right atrium, it would also probably be pretty plethoric as well and pretty big. So we can tell that there's high right-sided pressures, right ventricular dilation, right atrial enlargement as well. So this would be pretty supportive of a pulmonary hypertensive patient, especially if it's a chronic finding. And we see this on repeat echoes. All right, let's get back to the whiteboard. Okay, so we got the echocardiogram. It ruled out type 2, showed us right ventricular dilation, right atrial enlargement, some high right ventricular pressures, assuming that. So we assume that, and then we also assume that they have some high right ventricular pressures. The next thing I'd want to do is I'd want to consider a VQ scan. Okay, so I'm going to start off with an echo, rule out type 2, and then calculate my right ventricular pressures, assess for any right ventricular hypertrophy, right ventricular dilation, right atrial enlargement, the consensus of right heart failure. Then I'm going to do the VQ scan. The VQ scan will rule out type, well, let's see if you guys know. Would it be type 3, type 4? It's type 4. Because VQ scans are good for pulmonary emboli. So it'll help me to rule out type 4 pulmonary artery hypertension. Now you might be like, why wouldn't I do a CTPA? Because that diagnoses pulmonary emboli, or a pulmonary angiogram. VQ scans actually have been shown to be a little bit better than CTPAs in patients who have chronic distal pulmonary emboli. So think about that. So that's one reason I would do that, okay? Rule out that they don't have a type 4 pulmonary artery hypertension due to chronic pulmonary emboli. And you'd be able to see that due to areas of decreased perfusion in different parts of the lung on the VQ scan. Pretty cool stuff. The third and remaining stuff that I would also do is I get that high resolution CT scan, and I would also get a sleep study. So I'm gonna get a sleep study, which is a polysomnogram. I'd also do some PFTs, an EKG, and I'd finish off with some general labs, which may be somewhat helpful. So when I do a high resolution CT scan, this is actually an important one. When you do a high resolution CT scan, you're probably like, oh wait, I thought they do chest x-rays. They can do chest x-rays. Chest x-rays will kind of show somewhat of the similar features of a CT scan, but a high resolution CT scan will also help me to rule out a type 3 pulmonary artery hypertension. So if I use this high resolution CT scan, it'll help me a little bit. It won't guarantee me, but it may help rule out a type 3 and what else? Mediastinal tumors, sarcoidosis like granulomas, other compressive things. Type 5 pulmonary artery hypertension. Isn't that pretty cool? So that's one thing. I get the CT scan, I'll be able to get a good image of the lung parenchyma, the mediastinum. The other thing here is when you're looking at pulmonary artery hypertension, there's classic features, and it's like a weird dang name, but they look for what's called dilation. So you have just big pulmonary arteries, or we use the term pruning. I don't know why they call it this, but pruning of the pulmonary arteries. These suckers are huge. And it's because the pulmonary artery pressures are super, super high, so sometimes they kind of like dilate a little bit. So you may see evidence of a dilation or pruning of the pulmonary arteries on chest x-ray or high resolution CT. It's just better to get the high resolution CT because you can rule out mediastinal types of tumors, sarcoidosis, and maybe even assess for type 3 like COPD, interstitial lung disease. All right, my friends, so here we're actually going to be looking at a CT scan of the chest. Now this happens to be a CT scan where you can actually see some of the contrast kind of moving through the pulmonary vessels. Look how huge this pulmonary artery is. So there's like dilation or pruning, if you will, of the pulmonary arteries, and that's just due to that extremely high pulmonary artery pressure. So these are relatively common findings that you can see in patients with pulmonary artery hypertension. Look for that high right-sided pressures, right ventricular dilation, right atrial enlargement, maybe plethoric IVC, dilation, pruning of the pulmonary vessels, and again, in these situations, we're going to continue to keep going through the rest of the test, kind of ticking off the different types of pulmonary artery hypertension, really trying to elucidate the type 1 idiopathic pulmonary artery hypertension. All right, let's keep talking about this. Let's get back to the whiteboard. But that's not the best one, because guess what I can get from a polysomnogram? I can rule out type 3. Which type 3? Pulmonary artery hypertension. OSA. And maybe even to some degree, possibly, an associated obesity hypoventilation syndrome. So you see we're crossing things off the board. Okay, come down now. Let's talk about what we'd also see here. So we're ruling out a lot of things step by step, trying to really elucidate which one of these is type 1. That's really the question. I want to get to type 1, pulmonary artery hypertension, because that's a diagnosis of exclusion. I told you that. It's a diagnosis of exclusion. So PFTs may be helpful here. Why? Because PFTs will rule out your type 3, for sure skis, your type 3 pulmonary artery hypertension, such as COPD and interstitial lung disease, which are obstructive and restrictive lung diseases respectively. PFTs are the best for that. Because all I got to do is, I look at the FEV1, man, this is such a good spaced repetition, right? FEV1 over FVC, I look at the ratio. Is the ratio less than 70%, or is it greater than or equal to 70%? If it's less, it's obstructive, okay? If it's greater than, it could be restrictive, or it could be, guess what? Pulmonary hypertension. Could be pulmonary hypertension. Really, the ways that we kind of further classify these, if you guys remember, is an obstructive. They have a very high total lung capacity and a very high residual volume, right? And very low FEV1s. And then if you really wanted to, if you guys remember the DLCO, you could check the DLCO. If there's a low DLCO, that was emphysema. And if there was a normal DLCO, that was chronic bronchitis. If you do restrictive, you want to see, do they have a very small total lung capacity and a very small residual volume and a very low functional vital capacity. And then you can check the DLCO and see, do they have a low DLCO? That would be interstitial lung disease. And do they have a normal DLCO? That would be those extrapulmonary, so chest wall, pleura, some type of neuromuscular disorder, obesity. For pulmonary hypertension, the only thing that we do is we see normal FEV1 over FVC, a normal total lung capacity, residual volume. Here's the only other thing. They have a decreased DLCO. That's what's interesting, is that these patients have a decreased DLCO, which would be different from someone with completely normal pulmonary mechanics. Okay? If they had a normal DLCO, normal total lung capacity, normal residual volume, it would be a normal lung mechanics, but they have a decrease. Remember that. That's super helpful. All right, ECG, really, it's not that hard. We're not going to use it super helpful. It's not going to be a crazy great test, but it may be supportive. What are we looking for? Right heart strain. So you may see a thickened right ventricle, right ventricular hypertrophy. You may see right ventricular dilation and right atrial enlargement. So you could be looking for right atrial enlargement. You could see evidence of right ventricular hypertrophy. And if you really kind of dilate the ventricle and stretch it out, what also you may see? You may stretch those bundle branches and get a right bundle branch block. So really all you're seeing is evidence of right heart strain. Not super diagnostic though, but helpful. Here's where another test comes in. Labs. Okay, I've really ruled out a lot of these, right? And I've really come down to which tests are really gonna help me with type 1. One is echo. Tells me that there's high right heart pressures, right ventricular dilation, right atrial enlargement. High resolution CT tells me if there's a lot of dilation pruning. PFTs helps me to kind of lead towards pulmonary hypertension. Here's where some other stuff, labs. I can check a bunch of different labs, such as LFTs. What would LFTs rule out? Portopulmonary hypertension, cirrhosis. HIV. Remember I told you HIV can cause type 1? I can order an ANA. What is that going to tell me? Lupus. And I can also order the scleroderma antibodies, which will tell me about scleroderma. If I get all of these, it comes back elevated LFTs. I confirm that they have portal pulmonary hypertension. Boom. HIV, test them, they come back positive. Okay, there we go. ANA, they have lupus. Scleroderma, you see what I'm getting to. I'm doing all of these tests, and if I go through all of these and I rule out every single one of these disorders, what am I left with, my friends? Idiopathic or heritable, and I can even if I really wanted to check that gene mutation, but idiopathic pulmonary artery hypertension. The way to truly so if I've gone through all of these, I've ruled out type 2, type 3, type 4, type 5, and all the other etiologies that are not idiopathic for type 1, what I can really do to completely confirm the diagnosis, I can take a catheter, I can run it down the IJ, I can run it down the superior vena cava, down the right atrium, down the right ventricle, into the pulmonary artery, and at different points I can measure pressures, okay? But the big one that I'm really kind of concerned with is the pulmonary artery pressure and the pulmonary capillary wedge pressure. That's really what I care about. And so what I'm going to do is I'm going to measure the pulmonary capillary wedge pressure, and I'm also going to measure the pulmonary artery pressure. And I'm going to take the difference between them. So the difference between, so if I take the actual, it's called the transpulmonary pressure gradient, transpulmonary arterial pressure, is equal to the pulmonary artery pressure minus the pulmonary capillary wedge pressure. Now I'm going to kind of go through all this, right? In these patients, what's going on with their pulmonary artery pressure? We already said it's high, thus they have pulmonary artery hypertension. Pulmonary artery hypertension is going to be super high. What number do we need? Greater than or equal to 25. I need you guys to remember this. Please don't forget this. Here, let's do this. Second thing, what is pulmonary capillary wedge pressure indicative of? Please don't forget this. Is it indicative of left atrial pressures, left heart pressures? Yes. So if the pulmonary capillary wedge pressure was high, that would be type 1 or type 2 pulmonary artery hypertension? Type 2. So that would tell me it's type 2. It wouldn't help me to determine if it is type 1. Remember, type 2 is heart disease, left heart disease. That would tell me that the heart is the problem. It can't be the heart. It has to be the pulmonary vessels that are the problem. So in this situation, I want the pulmonary capillary wedge pressure to be low, less than, there's a particular number, random, but less than 15 millimeters of mercury, okay? Now, if I have less than 15 millimeters of mercury for the pulmonary capillary wedge pressure, it's low, the pulmonary artery pressure is high, and I take the difference. If there's a high pulmonary artery pressure and a low pulmonary capillary wedge pressure, what's the overall transpulmonary pressure going to be? High or low? High. So I would have a very high transpulmonary pressure gradient. These are the ways that we kind of secure the diagnosis of pulmonary artery hypertension. Now that we've gone through all of this, we've secured the diagnostics, we figured out how to determine which type it is, but really getting to the bottom of, is it type 1 idiopathic? We've done that. Now, how do we treat primarily type 1 idiopathic pulmonary artery hypertension? All right, so now treating pulmonary artery hypertension. So I talked about, we're going to only talk about type 1. And the reason why is, for type 2, guess what? Treat the underlying left heart disease. For type 3, treat the underlying lung disease. For type 4, treat the underlying chronic thromboemboli. For type 5, obviously treat the underlying sarcoidosis, mediastinal tumors, etc. For type 1, obviously if you can, try to treat the HIV, the portal pulmonary hypertension, their left to right shunting, their scleroderma, their lupus, etc. You guys get the point. But for those patients who have idiopathic, really the thing that we got to think about here is, how do we reduce the intense vasoconstriction and increase the vasodilation so we can reduce the pulmonary vascular resistance, reduce the pulmonary artery pressure, put less stress on the right heart, and put them at less risk of right heart failure, right? So the first thing we have to determine is this a vasoreactive pulmonary artery hypertension? So how do we do that? It's really cool. What we do is we introduce a little bit of a pulmonary vasodilator. So you give them, for example, let's say we first calculate, we calculate their mean pulmonary artery pressure. We've calculated it, okay? Once we have calculated, so we calculate this, we check that, okay? We know what that pressure is. Then what we do is, we give them a vasodilator, a pulmonary vasodilator. And after we give them the vasodilator, what we do is we want to know, were they reactive to the vasodilator? In other words, did it dilate the pulmonary vessels enough that it reduced their mean pulmonary artery pressure, right? And how do we determine that? Here's a great question. So how do we know if they were vasoreactive? In other words, they responded well to the vasodilator. And if that's the case, if they test positive for that, we can put them on something called a calcium channel blocker. For example, things like nifedipine. This is a really good one. People usually love this drug. If you have a positive vasoreactive test, you can do something called nifedipine. This is generally kind of a prophylaxis to prevent the further progression of the disease. So how do we determine if someone is vasoreactive? So we check their mean pulmonary artery pressure before we give them the vasodilator. After we give them the vasodilator, what we expect to see here is post-dilator, we expect to see the mean pulmonary artery pressure, the absolute value, so the absolute mean to be less than 40 millimeters of mercury. That's one. So one finding. The second thing is after we give them the vasodilator, we expect their mean pulmonary artery pressure to decrease more than 10 millimeters of mercury after the vasodilator. And we also expect the right ventricular cardiac output to increase or stay the same. If you meet all three of these criteria, in other words, you measure their pressure prior, give them the vasodilator, afterwards the mean pressure, absolute, is less than 40. They dropped from their original to more than 10 millimeter mercury drop from their initial one, and the right ventricular cardiac output either increased or did not change, that is a positive vasoreactive test. Put them on a calcium channel blocker. If that is a negative test, then you move on to the vasodilators. Other vasodilators besides nifedipine. So that's the next question. How do we determine the other vasodilators? So here's what I want us to go back to. There's three pathways that we can target. I know you guys remember this one. So here's this endothelial, so we got three little blood vessels that we took a cross section out, and the pulmonary vessels. One of them releases something called endothelin-1, and endothelin-1 activates this smooth muscle and causes vasoconstriction, right? So we know that the end process here is it causes vasoconstriction, okay? That increased the pulmonary vascular resistance. That's one of the problems with this disease. The other pathway is that it releases something called nitric oxide. Nitric oxide works on the smooth muscle, inhibits the smooth muscle, and basically is supposed to trigger vasodilation. And then the same thing is we have one more pathway, which is the prostacyclin pathway, and they release this thing called PGI2 that works on the smooth muscle, relaxes the smooth muscle, and causes vasodilation. In the type 1 pulmonary artery hypertension, these pathways are inhibited, and this pathway is increased. So there's usually less of this and more of this. That's the problem. What if I gave drugs that blocked endothelin receptors, preventing this vasoconstriction? So in other words, I give drugs that'll inhibit this process. I give drugs that'll act like nitric oxide or increase nitric oxide. So now I want to give drugs that will actually do something else. I want to give drugs that'll increase nitric oxide, which will cause more of this muscle relaxation, vasodilation, and decreased resistance. I want to give more drugs that'll increase the prostacyclin. So that's my goal, is I want to increase the vasodilation processes, and I want to decrease the vasoconstrictive processes by inhibiting endothelin-1 from working. All right, so what are the drugs that could actually give to basically block endothelin-1? Inhibiting vasoconstriction, causing pulmonary vasodilation, reducing peripheral vascular resistance within the pulmonary vessels, and then reducing that pulmonary artery pressure. These are endothelin-1 inhibitors. So these endothelin-1 inhibitors would be drugs such as bosentan. I just remember the Zentans, bosentans and ambrisentan. So if you remember the Zentans, that'll help you to remember the endothelin-1 inhibitors, reducing the vasoconstriction. The next category here is the nitric oxide. So I want to give drugs that'll basically act like nitric oxide or increase the nitric oxide. So how do I do that? I give drugs that basically help to increase nitric oxide, and these drugs are called PDE inhibitors, phosphodiesterase inhibitors. So phosphodiesterase inhibitors will help to be able to increase the nitric oxide. And so these drugs are going to be things such as, for example, sildenafil, and tadalafil. Now, what's really important here is whenever you put patients on PDE inhibitors, so phosphodiesterase inhibitors, it's important to remember to avoid, let's actually do this in red, avoid giving these medications with nitrates, or avoid giving these in alpha blockers. You wanna know why? You can drop the patient's blood pressure because this drug will also cause vasodilation. If you give it in combination with a nitrate or an alpha blocker, woo baby, you're gonna drop that blood pressure. So watch out for that, okay? The last pathway here, the prostacyclin pathway. I can give drugs that actually are gonna act like prostacyclin. So I'm gonna increase the amount of prostacyclin acting there to increase vasodilation. So these are going to be what kind of drugs? These are actually pretty interesting ones. These are called your prostacyclin kind of analogs, if you will. So these are gonna be your prosta PGI2 kind of analogs. And they're really, really cool. I really like these ones. So these ones will be like iloprost. The other one is called treprostinil. And the last one here is called epoprostenol. So these are really, really cool drugs to consider. If you see the prost in there, that's generally going to give that one away. So if you see prost, think about prostacyclin analogs. If you see the afil, that would help you to be able to remember potentially, oh, here it is. Here's the afil. If you see this will help you to be able to think about PDE, so phosphodiesterase inhibitors, increasing the nitric oxide pathway. And if you see syntans, you can think about the endothelin-1 inhibitors. So now we have a pretty decent understanding about how we would treat the type 1 pulmonary artery hypertension. The last thing here is if the patient is on all of these therapies or they've received one of these therapies and they failed, then the last option here, especially if they're getting worse and worse and worse, is super, super sad. But we may have to do what's called a bilateral lung and heart transplant. Just because there's so many pulmonary vessels that are affected and the right heart is super affected. So now we have to take these diseased pulmonary vasculars from these lungs, get rid of them, put in some new ones, and then we're gonna need kind of like a whole new fresh right heart. So unfortunately, these patients, if they fail all of these medical therapies, they'll require a complete bilateral lung and heart transplant, which is unfortunately not too common for these patients. All right, my friends, that covers this. Let's get into the cases.
All right, my friends, let's do a case here. So we got a 68-year-old male with no pertinent past medical history who presents to the clinic with exertional dyspnea. So we know with pulmonary hypertension, the most common clinical feature is dyspnea on exertion or maybe syncope on exertion. But either way, this is definitely classic pulmonary hypertension. And they have no past medical history, making me think that if they don't have any like heart disease, lung disease, pulmonary emboli, or any other kind of like compressive problems in the chest cavity or mediastinum, this is likely a type 1, right? So idiopathic, but let's keep going. So physical exam findings, again, it's usually nothing super, super obvious. Their blood pressure is appropriate, heart rate's normal, respiratory rate's normal, temp's normal, SpO2 is normal. So nothing is gonna pop up. If they've had chronic pulmonary hypertension, they may have some degree of evidence of right heart failure from the high pulmonary artery pressures. So do look for any evidence of right heart failure. In other words, do they have any JVD? Do they have any hepatomegaly, ascites, peripheral or pedal edema? Look for any evidence of that. So that is important to think about, but sometimes that may not be present. So how do we really go about obtaining a diagnosis of pulmonary artery hypertension? So we're going to have to do a lot of things. We got to rule out, is this type 1, type 2, type 3, type 4, is it even type 5? So with type 1, as I've told you before, this could be idiopathic, this could be heritable, this could be due to HIV, this could be due to scleroderma, this could be due to some type of like Abnormalities such as rheumatoid arthritis or SLE. This could be due to hepatopulmonary syndrome. There are so many different things that this could be. So let's throw off some labs. Do they have any evidence of lupus or scleroderma, HIV, LFT abnormalities? No. So no portal pulmonary hypertension, no HIV, no scleroderma, no kind of lupus that we see here is obvious. We get an EKG because this will help us to determine is there kind of like any heart problem or is there any evidence of right heart strain, which would be supportive of pulmonary hypertension as well. Not diagnostic, but supportive. So they don't have any evidence of like any MI or any kind of like acute abnormalities here. But we do see evidence of right heart strain. Their right atria is big because of high pulmonary artery pressures and high right atrial pressures. They have right ventricular hypertrophy because of high pulmonary artery pressures, and they have a right bundle branch block because of the remodeling of the right ventricle due to high pulmonary artery pressures. So all evidence of right heart strain. So if we get an echo, we'll see potentially a very large right ventricle, a very large right atrium, and high pulmonary artery pressures, but we should not hopefully see any left ventricular diseases. In other words, do they have a decreased left ventricular ejection fraction, any valvular heart diseases, any diastolic dysfunction? We shouldn't see any of that, but we may see some right heart strain and dysfunction. So what do we see? No valvular heart diseases, normal EF, normal diastolic function, but the increased right heart pressures are present, supporting right heart strain, telling us again, there's no type 2 cause. And then again, there's no obvious type 1 cause because we've ruled out HIV, portal pulmonary hypertension, scleroderma, and lupus. Could it be like, again, an idiopathic or heritable cause? It could be. Let's go to the next one. So if it's not type 2, because we ruled that out with an obvious EKG, no acute MI, no kind of like congestive heart failure that's present there as well, no valvular heart disease or abnormalities to support a type 2 cause. Is it a type 3? So look for any kind of obstructive or restrictive pulmonary diseases. Check your PFTs. If we check the PFTs, the patient has a normal FVC, a normal total lung capacity, but they have a low DLCO, that could support a pulmonary vascular cause. But it doesn't support in any way, shape, or form specifically an obstructive lung disease. If they have a normal FVC, a normal total lung capacity, this does not support an obstructive. This does not support any type of, in general, a restrictive lung disease. So as you can see here, if we check the PFTs and we go through this process here, nothing is really popping up as an obvious cause, especially with the lungs. Next thing is we got to rule out, if it's not that, could it also be anything obvious in the chest? So do they have any kind of other weird lung abnormalities that I'm missing? So make sure that there's nothing acute. There's no pneumonia, no pneumothorax, nothing weird here that I'm missing. And I don't see anything. When I get a chest CT, guess what I do see? Holy crap, that right side of the heart is huge and my pulmonary artery is bigger than I can even imagine. This thing's gargantuous. So there's dilation or pruning of the large pulmonary artery here. So definitely something, again, supporting high pulmonary artery pressures and supporting a lot of like pulmonary vascular resistance as well. So again, more supportive of a pulmonary artery hypertension that has no type 2, type 3 cause at this point. Let's go to a VQ scan. This will help me also. I could do a CTPA, but VQ scans have actually been shown to be more beneficial because I want to rule out a type 4 cause. Is there any kind of chronic pulmonary emboli that are present that are causing ventilation perfusion deficits here? Because that also can cause increased pulmonary vascular resistance. And I do a VQ scan, and if I did a CTPA, I would show no evidence of any pulmonary emboli with ventilation perfusion deficits. The other thing I could do is I could also, make sure that I rule out any other kind of causes here, that there's nothing else weird within the, heart, and I could cath them. So I could stick a Swan's-Ganz catheter, a right heart cath in, thread it up into the pulmonary artery, and then inflate a balloon to calculate the pulmonary capillary wedge pressure and to calculate the pulmonary artery pressures. Now, generally, whether it's type 2, type 3, type 4, type 5, type 1, all of them are going to have mean pulmonary arterial pressures that are high because they all can cause high pulmonary artery pressures, any one of the types of pulmonary artery hypertension. So the pressure is going to be high. If the mean pulmonary artery pressure is greater than 25, we already know that they have pulmonary hypertension. But the big thing is use that time also to rule out a left heart cause. So again, make sure that there's no other type 2 cause here and check the pulmonary capillary wedge pressure. If the pulmonary capillary wedge pressure is less than 18, it tells you that the left heart is not the problem. So again, we've ruled out with echo, catheterization, and an EKG type 2 causes. We've used PFTs, chest x-ray, CT scan to rule out lung causes. Type 3 causes. We've utilized VQ scans, and if we needed to, a CT pulmonary angiogram to rule out type 4 causes. And we could also use a chest x-ray and a CT scan of the chest to rule out things like type 5 causes. In other words, is there sarcoidosis? Is there mediastinal mass? Is there a big granuloma that's compressing onto the pulmonary vessels and causing increased resistance? So we could also rule out type 5 causes. And so we've gone through here, and we've even gone through the type 1 causes. Is it not idiopathic, in other words? Is it HIV, portal pulmonary hypertension? Is it some type of problem with a lupus, vascularity of some type, or anything like that? And we've ruled all those things out. So this really supports an idiopathic pulmonary artery hypertension. The next thing I need to be able to determine, though, is it a vasoreactive type 1 pulmonary artery hypertension? So I give them a calcium channel blocker like nifedipine. When I give them nifedipine, what I expect is it to dilate the pulmonary arterial system and reduce the pulmonary artery pressure. And if I reduce the pulmonary artery pressure, I should see evidence of that. And so that's what I need to do. I need to give them nifedipine. And then what I got to do is I got to determine, did it actually help? If the mean pulmonary artery pressure does drop more than 10 millimeters of mercury, that's a positive sign. And on top of that, if the total value, so let's say that the number was 60, and it drops more than 10, maybe it drops down to 30, is the number less than 40? And did it actually have no change or increase in right ventricular cardiac output? In other words, did it drop the pressure and potentially improve the right ventricular outflow? If it dropped the pressure and it dropped the absolute pressure more to less than 40, in other words, took the pressure, dropped it more than 10, then the absolute pressure that we have in the pulmonary circulation is less than 40. And if the pressure in the pulmonary arteries are lower, did it improve the right ventricular cardiac output? If it did, this shows a vasoreactive pulmonary artery hypertension that would benefit from a calcium channel blocker. So we would continue nifedipine if that was the case. If they failed the vasoreactive test, then we would use other types of analogs. So nitric oxide analogs, prostacyclin analogs, endothelin receptor antagonist types of drugs. So prostacyclin agonists, we would use things like iloprost, epoprostenol, treprostinil. And if it's PDE inhibitors, these are going to be things like sildenafil, tadalafil. And if it's endothelin antagonist, this would be like bosentan and ambrisentan. Okay, so these were the drugs that I would use if it's not a vasoreactive type. Now, here's the last thing that I want you to do. I want you to just completely quickly recap and like match the appropriate pulmonary artery hypertension to the potential etiology. So if I said idiopathic or acquired, so for example, scleroderma, HIV, lupus, it was some type of hepatopulmonary syndrome or anything like that, what would you say? It's type 1. If I told you it was from pulmonary emboli, so it's some type of like chronic pulmonary emboli or VTE process, then you would say type 3. No, that's type 4. Type 4. Type 3 is the lung. That's lung problems. If it's from pulmonary vascular compression from outside in the mediastinum, like a granuloma, a tumor, a mediastinal mass of some kind, and it's compressing on the pulmonary vessels and increasing the pressure proximal to that, that would be a type 5. If it's left heart disease, like heart failure, valvular heart disease, that's type 2. And then again, if it's any lung disease like COPD, asthma, interstitial lung disease of any type, that's type 3. Okay? So idiopathic or acquired type 1, left heart disease, type 2, lung disease, type 3, pulmonary emboli or kind of like chronic kind of blockage of the pulmonary vessels would be type 4, and then again, pulmonary compression, pulmonary artery compression from the mediastinum or outside structures, type 5. All right, my friends, that covers pulmonary hypertension. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.